Good morning, everybody. My name is Juanetta Ayers. I'm Executive Director for Commonwealth North. Thanks for joining us for this session of the Healthcare Reform Study Group. Our guest today is Darryl Means. He's the Regional Administrator for the Centers of Medicare and Medicaid Services with the U.S. Department of Health and Human Services. CMS has a big job within a big department in our federal government, and of course, they serve over 100 million Americans with healthcare services, including the Federal Healthcare Exchange. So with that, we've invited Darryl to provide us some perspective with regard to healthcare reform from the CMS and federal government side. Of course, we've already heard from some state perspectives, and if you were with us last week, we had an update on Senate Bill 74 from 2016, which brought in some big healthcare reforms for the state of Alaska. Many of those, of course, under waivers with CMS. So we welcome Darryl this morning, and I know everyone's interested in hearing your thoughts and perspectives, and as we look at ways that we can improve the healthcare system in Alaska. So with that, let me spotlight Darryl, and the floor is yours.
Thank you, Juanetta, and I want to thank everyone for the invitation to speak with you today, and also apologize. I know this has been hard connecting me with this group, but I certainly appreciate your patience as we work this out. So I'll actually be looking at the slides a little bit and working with you. When this first came to me, it was presented to me as we want to know about all the future policies and things that are coming down the pipe. And that is difficult for me to do, and I want the team to understand. It's tough for me in my situation to predict what policies are going to be approved or what is on the floor at Congress to be voted on and things like that, because that's how we get the laws. Once they're approved, that's how we get our marching orders for our policies and things like that. So I'm not at liberty to discuss that, but I do want to walk you through some of the things that I can discuss with you, and then hopefully at the end we can have some quick dialogue on this. Okay, good. Let me start off. There's a general disclaimer, and I don't think there's any press in here, but I do have to say, if there's press in here, this is not designed for press, and they should contact the CMS press office if they have any questions about that. So with that, let me just start with the vision, and I think this is just a straightforward vision that everyone can understand about CMS. We want to be a trusted partner, first of all, and obviously we have to be a steward of the monies that we receive from taxpayers. But we're dedicated to advancing health equity and ensuring that everyone who can, who needs it, can get coverage, and improving the outcomes of health outcomes so that people can stay healthy. That's the bottom line here. The way we do that is through our 6 strategic pillars, and our new administrator came through and looked at what we're doing and has developed these pillars. Obviously, the first one is advancing health, but we're also talking about disparities, within the healthcare system. And I think we all understand that these disparities are there. We want things to be affordable, as far as healthcare to be affordable. And many of you know the marketplace is open, and that will end December 15th. And we've seen a big uptick in the amount of people getting insurance coverage through the marketplace. In fact, we've seen more than ever. We've had 4.6 million people enroll during this enrollment period. So it's big, and I would say to all of you that if you encounter people who need health care, that they need to go out to that health care market if they're not Medicare or Medicaid. One of the things, that third slide, or this third box over, is the partnerships that we want to build within the community. And this is, I think, where all of you can help and where you want to be involved, because this is where the policy making comes in. And I think having open dialogues with all of you and engaging with you can help give me information that goes forward that may help shape future policies. I can't guarantee that, but our administrator and our leadership back in Baltimore really wants to know how our policies and procedures are impacting people who are in, for the lack of a better word, in the field and engaging with patients. So, and then we want to be innovative. We want to make sure that we're driving that value-based, and obviously we want it, we say person-centered now, but some of you may know that as patient-centered care. And we want to make sure that these programs are around for people. We all know that this comes out of the trust funds, and we want to make sure that these funds are protected in a way that there's no waste of this money, and we're looking into that as well. And obviously, internally, we want to make sure from a diversity, equity, inclusion, and accessibility standpoint that CMS is promoting excellence within. And that's what that last box shows us. What have we learned from COVID? And this is the box that talks about what we've done and what we've learned. And we all know that COVID was and is very terrible, and it having a negative impact, not only on people's lives and families and friends, but also on our economy and everything else. So we want to make sure that we understand what is happening around COVID and the changes that we can make. And one of the things, I just put that up here as far as the vaccines and the treatments, millions of Americans have received this, as you all know. And as a result of identifying who needs it, identifying who's sick, we've been able to get to the point, I don't want to call it stabilization, but we're not seeing the amount of deaths that we saw going in, and the deaths are not as tragic as they were, where people were going in and 30 days later, they did not survive. So, but there's been a lot of challenges, and we understand that these challenges over the last, I have 19 months here, but it's probably almost 2 years now, has been very painful on many of you or many people in the healthcare infrastructure as we have. Can we make sure everyone's muted just so it doesn't disturb those? Some of the things we did, as you know, we took action and on the proposed rule for home care workers, and we did other things such as educate eligible immigrants, and we looked at the ESRD folks and made sure that we could do greater access. Home-based community services is another thing that we looked at as well, and we tried to make sure that they were able to receive the care that they needed. We vaccinated millions of people, obviously, or ensured that all of our beneficiaries, I shouldn't say we vaccinated, but we ensured all of our beneficiaries had ways of getting the vaccine, even if they were homebound. And then, we continue to look at where are the gaps in the healthcare system that COVID brought out, and we've all seen these. So we're trying to ensure that we're taking a deep dive on this as things, as we progress through this, and we're looking at what's valuable and what wasn't valuable, and what was good that we did, and what benefited you, and what we can keep. Obviously, the emergency declaration gave us the authority on this, but as you know, we've had blanket waivers on things such as eligible providers, audio only, telehealth. And I just have bullets down here. I didn't go into the details, but EMTALA, enforcement and things like that. We did all of this so that caregivers could focus on what was in front of them, which was saving lives for those who had COVID and those who continue to have COVID or to be infected. So these flexibilities were important, and it was unprecedented the way we did this, to come out with these blanket waivers. We've never done that before. So we took a chance. It needed to be done, And I think it did help everyone, or at least some of the feedback that I've received said that it helped everyone. Other actions, obviously everything that we do, we want to make sure that we're pointing back to our strategic objectives and our pillars and make sure that everything's correct. We talk about the 3 M's here. That's our business: Medicare, Medicaid, CHIP, and the marketplaces. So, we're looking at that. We're looking at how do we improve that. I already talked about healthcare.gov, how some of the new financial assistance that's out there is helping to reduce plans, and many people who are already in the plan found this year that they could get a new plan for $10 or less. And we continue to ask ourselves, in everything we do, are we, one, advancing health equity, and how? How are we advancing health equity? And to that point, this brings us to our CMMI, as we call it. CMS has a lot of acronyms. The federal government in general has a lot of acronyms, but our Centers for Medicare and Medicaid Innovation, better known to most of you as the Innovation Center. We support development and testing of innovative health, care models. And we do that across the United States, and a lot of that involves communities and individuals just like you, and healthcare, individuals and entities throughout the community. And the overall authority on this obviously is coming out of MACRA, which was, passed by Congress, back in 2015. So that's kind of our guidance on this. The Innovation Center, just like CMS, and you'll see this if you have presentations from other departments, we're all trying to cascade and have these pillars that are valuable to us in helping us track what we do and helping us ensure that we're providing the best level of care possible out there. And I'll go through some of these just real quickly. Driving accountable care, I think that doesn't need any explanation, but we want to make sure that individuals who come through the healthcare continuum ensure that they get that the care that they get is accountable, and that the quality is high and that the cost is appropriate. I think that's the bottom line there. And in advanced health equity, all of you will hear things about health equity, and you may be doing things yourself about health equity. It's very important. But our CMMI models at the Innovation Center are focused on the underserved populations, and I don't think anyone would argue with that. We know through data that there are populations out there who don't get the care that they deserve, and we're trying to make sure that that happens. So we're looking at all sorts of data and cross-feeding data to ensure that through our support care innovations. And we're looking at strategies for healthcare pricing and affordability to reduce unnecessary procedures, if you will, and duplicative care. Obviously, we don't want people readmitted to fix the same problem. It's costly to everyone when that happens. So, we're looking at that. And then we want to partner with the community to achieve this transformation. And I say this personally, I know that the federal government and maybe CMS has had, or may be seen in a negative light through a lot of people. We're regulators. I can't avoid that. But at the same time, we put our offices out there to be utilized, and we put them out in the communities and in the regions so that you do have a voice, a face, a person. We don't want to be seen as an entity, a building, a name, 3 letters. But I try through our outreach to get my team out there and let people in the community know that John or Jane or whomever is CMS. So when they think of CMS, they think of a name, and then they get a contact that they can call. And I'm trying to ensure that my team's available. In other words, you don't get a voicemail. If you do, you get their voicemail and they will call you back. but I try not to steer everyone into these, the infamous voice mailbox that no one responds to, because we think that's not the way to go. So we believe in partnership, and we think that's the way that we should be going. Equity versus equality. I think you've seen many slides like this, and you may have some of your own. But the bottom line here, we want to make sure that people have the same opportunities or equal opportunities to achieve their best, if you will. And if you look at that slide, yes, a wheelchair can be in a race, but they're at a disadvantage right off the bat. But if you provide them with the apparatus that they need to be competitive, then they can compete as well. So that's how we look at equity and health equity. It applies to that as well. I don't want to go into all the social determinants of health. I think all of you may be well read on that. But I do want to point out some things that it's estimated that between 70 and 90% of health is determined by these determinants. That's a lot of people. We all know that. And what that means is maybe that those who are underserved do not get the ability to get information and to understand the healthcare system. And so we want to make sure that we eliminate that and that we give them that opportunity and that we ensure that it's equitable in the sense that everyone has the ability to do the same things. Foundations, we can talk about those a little bit, but data collection, when we talk about real data, we're talking about race and ethnicity and language. And I want to be clear on that because a lot of people say, data is fake or we want real data. So, when we talk about real data, that's the data that we're talking about. But we need to be able to analyze this and stratify it and make sure that it makes sense. And that we need to also foster a culture of equity. This is a cultural thing. People have to want to change the systems and ensure that everyone can participate and get the health care that they need and stay healthy. Quality improvement, we've talked about that before, and all of you know that that has been something for years in the healthcare environment that we've looked at. We've always wanted to save money and look at where we can cut costs. And for those profit type of organizations, obviously it's important to them because cutting cost means, in their case, higher returns. So it's something that's always been looked at, but through our innovation center, we're looking at these quality programs of how do we reduce these disparities? How do we get to a position that we're all looking at cost savings? The big thing now that a lot of you have heard is the drug pricing that the administration is working on. As all of you know, all of these things are like gears in a watch. CMS is only one of those gears. So we can only do so much, but we can be that force that is pushing for this change. And that's what we want to do. Interventions where we need to, but we definitely want to get that feedback to make sure that we're staying on target with our efforts here. Were there any questions? I think there's some things in the chat.
Yeah, we can get to those at the end of your prepared remarks. If
okay, good. I didn't want anyone to think I was ignoring them. This is our framework. I don't think it's anything complex, but we got to understand where the disparities are, and I think we do a good job. And that's where you can help us as well, because Alaska, and I hate to use this word, but it's true, is unique. And we all know that with the Medicaid population you have up there, the distance issues that you have as far as being rural, some of the disadvantages that you have in the wintertime as far as getting to places and ice roads and things like that. We need to understand, what does that mean? Does that mean that that's creating an environment where disparities exist, and how can we mitigate those disparities? And getting to the solutions is the bottom line. We want to make sure that we're driving these solutions and that these solutions are worthwhile. and then sustaining actions. We don't want this to be, as they say, a one-trick pony. We want this to be something that is recurring, something that we're always looking at streamlining, and something that makes a difference. And we talked about disparities. These are just some examples. You've heard words like, Black, Hispanic, API, AAPI. Now, it's AAHPI or something like that, because we put in Hawaiians and things like that. Or you may hear terms like BIPOC. But the bottom line is that we're looking at people who traditionally have not received the level of care that the majority has received. And so, we're looking at all the data and all the experiences, and there's all sorts of metrics of measure that just too much to put here. But I wanted to highlight that these are some of the things that are coming out, and that this is proving that many people of color, if you will, were worse or received worse care than their white colleagues or beneficiaries. And these are some things that we're trying to change and see if we can streamline this to the point that it's equitable to everyone. As I said before, we're interested in your partnership. There's over 6,000 people here at CMS. We have over 100 people in the Seattle office alone, and they cover a myriad of responsibilities and things that we do. As you know, healthcare is complex, and CMS is a complex organization. This is one reason why I like to do outreach and give information out to people about my team, and give their information, their direct information, again, their email addresses, their information. And whenever that Ronald has been one of those people, you could reach out to him, he responds. And if he can't respond right away, he responds, in kind, in order, in an appropriate amount of time. So it's important to me that we do that. And as I said before, that people see a face when somebody says CMS. My goal would be for them to go, oh, CMS Seattle, do you know Darryl? Do you know Ronald? Do you know, Juan? Do you know this person, that person? Call this person, here's their information. Because that's how we build community, that's how we build partnerships, and that's, in my opinion, how you sustain trust relations with the folks in the field. Again, we're not just a brick building back in Baltimore. So, so we want to build those closer, and to do that, we need your feedback. It's very, very important to me that we get your feedback, and with that, I'll end and say, what are your thoughts? How are things impacting you? What is it that keeps you up at night that we can work with you on and help?
Great. Thank you so much, Darryl. We will, in that regard, provide some questions and feedback, I think, for you this morning. We have several of our co-chairs for the Healthcare Reform Study Group online with us this morning, Ralph Townsend, Preston Simmons, and Kathy Giesel. And I'm going to call on them for any first questions. And it looks like Ralph is turning on his camera, so I'm going to turn to Ralph first. We will get to the questions in chat, so please feel free to submit questions in chat. And you can turn on your camera, raise your hand, and I will call on you as well. So let's turn to Ralph.
And I did put my email address out there. Obviously, if people have questions, suggestions, or things like that, I'm not in the position to do copious notes, but
Okay.
you can follow up with me in email. I'm happy to respond that way.
Great, thank you.
Thank you very much for joining us, Darryl. I really appreciate it, helping this group understand the interconnection between what goes on at the federal level and the state level is obviously very important. You touched on a very interesting issue in your talk about what's going on in the ACA Marketplace enrollment for this year. I'm curious if you have a perspective on the overall changes in enrollment that occurred during the COVID period. As you know, the ACA Marketplace enrollment has been, I think, remarkably stable over that period at about 11 to 12 million folks, which is where it was pre-pandemic, whereas Medicaid enrollment has increased by about 9 or 10 million, which that latter increase is not unexpected. But is there data on the dynamics that COVID has caused in terms of the ACA Marketplace, Medicaid coverage, and other coverage? Obviously, people losing their jobs lost coverage at work, but is there an understanding of the dynamics between the ACA Marketplace and Medicaid in particular?
Well, Rob, that's a good question. And I know within CMS, we are tracking that information. I'm not tracking it personally in the region. But what I do know, because I do radio and television for the marketplace itself, actually, I just got off a couple of those spots. What I do know is that across the board, we're seeing that enrollment in all of the marketplaces across the nation is up. Even in those state-based marketplaces, we're seeing gains of at least 5%. We do recognize and did recognize quite early that people were losing health insurance. So what we did was the special enrollment period, or the SEP, at the beginning of last year, or the end of last year, the beginning of this year. And what we saw from that was a big spike, almost 3 million people during that enrollment period enrolled in healthcare.gov and received insurance. And like I said, just during this enrollment period alone, we're seeing upwards of almost 5 million people who are getting it. So what we know is that there's a need. There's a need for healthcare. We know that there's a need for affordability. And so what we believe is that the marketplace is driving affordability. Affordability is driving people to the marketplace, and people are getting the care that they need, the health care that they need. And one of the things we try to tell people that these aren't skeleton plans. These are complex and comprehensive plans that cover everything, as well as the 10 benefits that are mandated that they cover. But these are things that people can use for the entire continuum of care.
Thank you.
Okay. All right. Thank you, Ralph. And Preston, did you?
Sure. Darryl, thanks for joining us today. Good to see you.
Good to see you again too, Preston.
Just wanted to ask you what you have seen as some of the more successful CMS demonstration projects around the country that that you've seen that drive affordability and better value for the communities.
Yeah, it's hard for me to pick one because there's so many going on, Preston, as you know, at any given time. So many different states have been in these models and modeling. But I think all of you see some of the things that come out with our payment rules and things like that as a result of these. And these are the improvements that we make based on the innovation and the projects that are in the innovation process. What I can say that I see through this process is quality is increasing. I know you like to use the word cost containment up in Alaska, but costs are being curbed where we can, and more people are gaining access to better quality care, and that's the objective. Overall, I think if you would track mortality rates and things like that, I would hope at some point in time we would see that people are sustaining life because they're getting the care that they need and not dying needlessly because they don't have access to care.
Great, thank you. Juanetta, you're on mute.
Thank you. All right, Darryl, we do have some questions in chat. Tom Crafton is with us, and I'm going to rephrase this just a little bit. There are 800 people on the wait list for Medicaid in Alaska, and I think you can see Tom's question as well. And so his question really speaks to individuals having to advocate for themselves for eligibility and the dynamics between the federal and state government and the individual having to advocate for themselves. How does a person navigate that, and where does Medicaid step in terms of enforcement?
Yeah, that's a good question. Obviously, we do depend on the state Medicaid director and that staff to ensure that people understand what's available to them. We have requested, I know the administration has requested for states who have not expanded Medicaid to really give that some thought as well, and that has helped out. So, I mean, we try to keep our finger on the pulse of what's going on, and in Alaska, the way we reimburse is different than the way we do other places because we kind of understand the need up there. But that's about all I can really speak to at this point. I don't know, who's the question from?
Tom Crafton, he's basically speaking to the fact that the onus is on the individual to advocate for eligibility when someone has been waitlisted, and what's the Tom's turned on his camera, and I'm going to go ahead and call on him, and we're not going to get into individual circumstances, so please keep that in mind. Go ahead,
Sure.
Tom.
Thank you for meeting with us. We really do appreciate it. But my question is the clarity of why is the onus on me or my daughter to hold the state accountable for Medicaid mandates and law, such as when someone is eligible for institutional level of care, they must be served in a reasonable amount of time. A decade or more, I don't think is reasonable. And medical needs are no different than disability needs. If somebody had a compound fracture, they wouldn't put it on a wait list. And you can't compare people that are on a wait list. It's exactly what the state of Alaska does. They have this terrible tool that is only crisis oriented and weakness managed, measured on weaknesses. And that score is compared to John and Sue. And then whoever has the worst, highest score gets pulled for a waiver and the others wait for years and years. So anyway, I think you're probably well aware of this conversation, and we don't know what to do as individuals. My daughter's sitting on a wait list and I have to stay home for 20 years
Okay, Tom.
to help her. So
Okay, thank you.
Thank you.
Okay.
Tom, I appreciate your candor on that, and I will definitely have to take that back and work with our Medicaid folks. But as I said, we provide the funding to the state to run the Medicaid programs, and we review their SPAs and things like that and make sure that they're in line with what we require from a regulatory standpoint, but we don't manage the day-to-day operations at the state level, nor do we oversee that. That is the responsibility of the state and the leadership of the state. But I'm happy to look into not your specific issue, because that's not what we do, but if there's an overall problem that you feel is at the state, CMS is happy to look at that to see and clarify if there is a problem. But unfortunately, and I don't mean this disrespectfully, you do, through your voting and things like that, have to hold your elected officials in your state accountable. And we say the same thing at the federal level, where people want changes. We really do recommend that they get in with their Congress people and let them know what's happening, because that's where things start to change in the state and federal Congresses, where they enact the laws.
Okay, thank you, Darryl. Thank you, Tom. Darryl, Marge Stoneking with AARP is online with us, and she's asking in chat, what flexibilities and innovations implemented during the pandemic public health emergency will be continued to better serve older Americans? And of course, I can, again, we're not talking about personal stories, but I can say that some of those measures have been very helpful in my family during the pandemic. So what do you see moving forward there?
Well, first, let me say hello to Marge and thank you. We've partnered very closely, I think, with AARP throughout the nation. And it's been very helpful. with reaching our beneficiaries and getting information out to our beneficiaries quickly. So thank you for that partnership. This one's tough, and here's why. The waivers were given because of the public health initiative, and it was only to be run as long as we're in that public health situation. And when it goes away, then those waivers go away. Now, when it goes away, the waivers go away, and we go back to what the current law says we can do. And as I said, CMS is looking at all of this to see what's working, what's not working, what we can do under the law and what we can't do under the law. If there are things we can do, I can't speak in advance, but I'm sure that that will be taken under strong consideration as to whether we should do it or not. Some of the things we're looking at is like telemedicine and things like that, and telehealth. And we've heard resoundingly that that has been very beneficial. So we do have our lens on that. I'm not suggesting that we're going to change that. But this is the way, again, through partnerships, as we get this data from you, that data can go up and hopefully help shape the future policies to where it's inclusive of the things that are important to you. Now, there are many, many hundreds of waivers out there and hundreds of things that have been waived. I don't think any of us can expect that all of those are going to become the norm, and they won't. But where it's practical and where it makes sense from a quality, health, improvement standpoint, those are really looked at very closely. So March, did that answer your question? I don't want to seem like I'm tap dancing, but that's the reality of it, and I just want to be very straightforward with you on that.
Thank you. Are there particular learnings that CMS has already identified in this area from the PHE waiver experiences?
Yeah, I mean, there were things that we learned and some things that we came back and put out new waivers on during this PHE, so yeah, we're learning every day, and now we're getting new variants, as you know, and we're looking at those too to see if we need to do anything further. What we've heard, though, from at least the provider community and the hospital community was that they were very appreciative at the speed at which CMS wavered things. Now, there were complications. We all know financially, this has been a burden on everybody, the states, the hospitals, because everybody is impacted by this. Individuals are losing their jobs. So this has been impactful across the board. We've tried to do what we could within the bounds or confines of what we can do to make it easier on you.
Thank you.
Okay, thank you, Marge. Thank you, Darryl. I'm going to bring Elizabeth Ripley in just a second, but I just wanted to comment that with regard to health equity and bridging some of the discrepancies across healthcare, that Alaska has been a real pioneer in telehealth, and it's made it possible to increase the standards of primary care, in particular across Alaska, in very dramatic ways. So I don't think there's a need for a demonstration project. Alaska has been demonstrating that telehealth and telemedicine has been very impactful for well more than a decade. So I just think that we stand as an example in that regard. So let me bring in Elizabeth. Elizabeth, go ahead.
Good morning. Thank you for your time today. I run a healthcare conversion foundation in the Mat-Su Borough in South Central Alaska, our funds come from our local hospital in a nonprofit for-profit partnership. So just kind of in full disclosure. So my questions are really, I have two different questions, one around data and one around cost. And I know that we're doing some work here at the state level and certainly at the local level on some of these issues, but would really like to hear from you what role, if any, CMS plays in these. And so one, you talked about, equity and health disparity, and as a foundation that is really epidemiologically driven, we've really focused on the data and we're learning over time to decolonize that data. But it's really at that local level, super local level, that we actually can then see those disparities and see those equity issues come out. And so, is there, what role is CMS playing in getting that kind of more hyper local data that then local residents can use to eliminate those disparities and address those equity issues? And the second question, kind of tagging on what Preston said, I think CMS has a lot of, I can just pause if you want to answer the first question. Okay, the second question, I think CMS has had a lot of effective demonstration projects. And, I serve on the hospital board of directors, and for years we've been hearing, we need to be ready because CMS is the most efficient payer. And you have driven quality and cost, pretty effectively in some of your projects, but the third-party payers have not caught on, and the third-party payers have not really adequately taken some of the steps Medicare has, even though for years we've been hearing at the board level of hospitals, we need to be ready for all payers to pay what Medicare pays. They're not doing it, and that's part of the cost problem. Medicaid expansion, at least speaking for Alaska, it was a winner for our hospitals. And that cost shifting to third-party payers, it continued even though costs did not increase. So, and that's not, true for all hospitals. So, I'm kind of painting a broad brush here, but so what partnerships or incentives or push can CMS give those third-party payers to really actually tag on to what you have done and reduce cost over time?
That's a complex question, Elizabeth, and I really can't answer. I'm not even going to sit up here and lie to you. When you start talking about hospitals and third party, these are entities that are not federal entities. These are private organizations. So there's only so much that we can do. We do try to ensure that if Medicare, Medicaid money is out there, that they're complying with what Medicaid and Medicare says, that they're in compliance with that and that they're following those rules. So that's pretty tough. You talked about local data as well. And I think all of you will agree that data is something that's very hard to understand. There's a lot of megadata out there and metadata, everything else. And when you look at it, there's so much data. How do we know that the data is accurate? How do we keep the data accurate? And that's something that our Innovation Center looks at, and others, our CPI folks and others within CMS are looking at how do we round out that data? How do we get that data? Because the data is only as accurate as what's being reported, and some of the data is coming from the state, some of the data is coming from counties, some of the, it's just this, thing of there's so many different reporting systems out there that trying to understand the data. But that's something that we're really looking at. We're really discerning over how do we ensure that this data is good, because we're trying to extrapolate things that will tell us whether healthcare equity is improving, and how do we know that? So these are some of the things that we looked at. And you're right, the demonstrations are very worthy, and where they are worthy, there's criteria obviously under that demonstration as to the financial impact on the system, and several have been adopted, and there's other in the pipeline as well. And this is where organizations like yours may want to think about a demonstration. How do we work harder to get that third party payer online, and what's the value of that? How does that improve the health? How does that improve obviously effective care and timely billing means that you can continue to provide high level care to people. So it's important that we look at those things as well. But I really can't answer the third party payer piece as far as what can we do. I would appreciate it though. I did put my email address in the, I thought I did, in the chat a little while back.
Yeah,
But
it's in there, and we'll provide it as well.
Yeah, and yeah, I did put it in there, and then I can look into that a little bit more, but I don't want to mislead you. I don't want you to think that CMS can just reach their hand in and change that situation. That's not going to happen. But at the same time, I can get more information on how we can approach this, or how we may already be approaching this, or if we can approach it at all, other than saying, if you want our reimbursement rate for our our rates, then you have to do what CMS says, in a sense, and have to be in compliance. Okay.
All right, thank you, Elizabeth. Thank you, Darryl. We have some more questions for you, Darryl. Miranda Walso is asking, Alaska has experienced a very significant cyber attack on our DHSS system, and she's wondering, and I'll just, she says here, and I'll emphasize that it has been very disruptive to the availability of information and services from our State Department. I know we've got some folks online from there, but how does CMS see their role in helping states with protecting the data systems that they manage, including, the 3Ms or 4Ms, I think it was, and secure and protect the information about beneficiaries?
Oh, there's some tough questions today. You all get together and decide. You're gonna beat me up on these. No, it's a good thing. I think if you look at the nation in general, cybercrime is a problem, and everyone's trying to protect their information. We've seen internets shut down. We've seen all sorts of hacks. Obviously, the information that we have, we know is valuable out there on the black market or the dark web. So we try to do all that we can to stop from being attacked ourselves. And so I don't know if there's anything that CMS can do at the state or local level, because you have your IT people and your cyber people right there who are hired just like we hire ours to prevent this from happening. But on occasion it happens, and even the federal government has been hit. I'm military, ex-military, and in the DoD, and I know that database was hit. My information was compromised. With all of the lockdowns that we've had, there's always somebody working the how to get around those, and cybercrime's a big thing. So we're looking at that. We're looking at how do we ensure that the data that we have on our patients are kept confidential and not subjected to a cybercrime. But it's hard to say that CMS can do anything in 50 states to improve that. I think the states really have to look at how to protect their systems. And it's not just their healthcare systems, their financial systems, things like that. We do have a fraud organization who goes out and we look at fraud, and we have a cyber group who does their best. Now, sometimes that's problematic because we feel sometimes we can't even get things, like right now, if I was to come to you, if I was in the room with all of you and I was to try to connect my computer, I would have a problem on the network. It wouldn't allow me. Or if I downloaded everything to a thumb drive, it would encrypt that thumb drive and I couldn't use it there. So, it does create problems, but the design of it is to prevent the loss of data. So did that help? Did that answer the question? I'm
going to bring Miranda in, and Miranda, did you have any follow-ups on that?
Yeah, no, I appreciate the challenges of managing across the different states. I guess I was curious, interfacing with all the different states and the requirements, that Medicaid has for the reporting of it, whether there were any suggestions or standards, or just kind of acknowledging the severity of the impact when the data is compromised.
Unfortunately, Miranda, I can't answer that question, to be honest. I'd have to reach back to our IT people and our cybercrime people to see what's going on. That is all happening at our headquarters in Baltimore, and I'm not copying out. I don't want anyone to think I'm copying out. It's just the truth of the matter is I don't see what's happening. I know when I log on, I get a little splash screen that says, make sure your data is secure. Don't log on to open networks and things. So I know they're doing something. I know we get tested at CMS every once in a while with fake emails to see if you click on them, and that click is reported, and people get admonished if they're just clicking on anything and going out there. So we try to do things internally to help it. And I think everyone's trying. But cybercrime is a problem, and it's going to be a problem as long as there's people who want this information and who can profit from this information.
Okay, thank you, Miranda, and thank you, Darryl. Darryl, we have another question from Marge Stone King. She's asking if you could describe what CMS's role may be with regard to healthcare workforce development. Of course, Alaska had a critical shortage in many in-demand healthcare occupations prior to the pandemic, but those issues have certainly been exacerbated by it. And she's wondering what's happening to invest in providers at levels not previously addressed, and certainly things like home healthcare workers and those kinds of occupations are of critical importance for older populations. So what role will CMS have with regard to workforce development in the healthcare field?
I think our role will continue just like it's been. We try to get providers in the system. We've had challenges, as you all know, up in Alaska because of the reimbursement rates. And, the reimbursement rates are set. And we, as I said in the presentation, we want to sustain the trust funds as long as we can, so we don't have a lot of room in there. I think in Alaska, we've made some changes up there to help with the situation up there as far as payment models and things like that we've done up there. But that's another hard one for us to respond to, because it's on the provider to accept being in Medicare, and once they sign on and accept Medicare patients, then we go from there. Now, during the pandemic, and within this pandemic, we have waived a lot of things to facilitate the cross-utilization of medical practitioners, if you will. And we did a lot of this with nurses and nurse practitioners, and we waived a lot of things to be able to utilize people in capacities that they may have the knowledge and education, but technically they weren't in these roles. So that's one way that we've helped with the staffing, to allow you the flexibilities to do those things. But as far as getting more bodies into organizations, I don't know that that's a CMS role.
Okay. All right. Well, I don't see any more questions. Oh, wait a minute. Sorry, I do. Michelle Geralt is with us, and she's asking what's the best way to give you stakeholder feedback from those receiving disability support services. And she uses an acronym, unfortunately, I'm not aware of, with HCBW, and being able to engage in some dialogue specific to what the system does and does not result in desired outcomes for full lives. You're not going to see it.
Okay, I was looking for it, but
yeah.
Well, the best way to get things to me is, through my email address. I do try to clear that out daily. It doesn't always happen. I'm not going to lie to you. I do run arrears, probably 50 to 100, depending on the day. But I do eventually get through all of them. And, if I can't get to something, I will assign it to someone to look at it. But I don't want you to think it falls into a black hole. It may seem like that, but I do respond to that as well. So that's the best way. And that's not a blank email address, or it doesn't go into a queue. It comes directly to my mailbox.
Great. All right. Well, I'm going to call on our co-chairs again, Ralph, Preston, and Kathy, if you'd like to come in and ask any closing questions or any closing comments. Ralph?
Darryl, I think Elizabeth Ripley raised an interesting direction that CMS has been leading both Medicare and Medicaid across the country, and that is the evolution of value-based care, of measuring quality, which I think is candidly is a data challenge. If without saying where the administration is going, if someone's trying to understand the evolution of healthcare, it seems to me right now that is the big issue going ahead. Just as in my youth, back in the 80s, when DRG compensation came in at CMS, it drove a tremendous change in the way reimbursement occurred. It seems to me that we are at a place where CMS is the leader in moving towards understanding how we measure value, how we measure quality, and move ahead. So if you were explaining to someone where we are on that curve and what kinds of things, because it's not going to be a one-year change or even a one administration change, what would you say about that transition that we're obviously going through?
Rob, I can't speak to the future, but personally, Darryl Means speaking now, I would say I would sum it up as health equity. And I think that's the direction we're going. If you look at health equity as, a system, then we're looking at how do we ensure everyone gets the same access to the same quality of care. How do we make it affordable? How do we get rid of waste and excess in there? How do we stop people from having to go back in to get the same thing done over and over? How do we ensure that quality is there, the cost is appropriate, and that the care they get is helping to sustain their life and not just whenever they can go into emergency? So I would say that health equity is something that is very, very important to CMS at this point. You'll hear a lot more of it coming out. But I think that's the driver when you think about it. That's the driver. And that's the cultural shift that we have to have in the health community, because when you start thinking about that, that means I'm aware of providers who won't see people from the LGBTQ community. And so you have organizations coming up like Queer Docs and things like that to service these folks. But we got to get to the point that culturally we're looking at everyone as patients and not as a group of people, if you will, based on color. But we're educating everyone. We're getting everyone in the system and getting them the information that they need to keep their health on par. No crystal ball. Sorry.
Thank you.
Preston, go ahead.
So no additional questions, but just encouragement in terms of, I think as Ralph stated, CMS is the largest payer out there and has done a nice job in terms of the national framework of continuing to drive from that fee-for-service to value-based care, which we know that works really well. And just would encourage continued investment and around the innovation division and more resources in that. I think there's still a long ways to go in that, and a lot of good learnings that will help us not only as Alaska but as a country. Other things there was a question early on, I think, about what CMS foresaw that they could do that would be longitudinally helpful out of the pandemic. And one of those areas, I think, are licensure compacts or multi-state compacts. There is a lot of redundancy and waste that people do in licensure in multiple states or those national processes that really helped us in a time of need, but would also help us, I think, longitudinally to make recruitment and use of physicians and nurses across state lines a lot easier as well.
I agree, Preston, and this is where we need the state input, because as you know, a lot of that is mediated, if you will, at the state level. But that's one of the things that we did do during the pandemic was waiver some of that, so that providers could work across state lines, especially those border providers, and they could accept patients from the other states and be reimbursed for it, because the focus was on ensuring that people were healthy and that we could mitigate COVID. So I don't know whether those will stick, but that is something that, you know, we have looked at as well, because that was something that people had asked for and said that is very valuable under COVID. Now, you know as well as I know, it's complicated though.
Yep, it is very
Because of
complicated.
reimbursements and things like that in the different states, and that's something that needs to be worked through as well. And certification and licensure, things like that. Yeah, so it's very complex, but we are looking at that as well, I'm sure, back at our headquarters.
All right. Well, thank you, Preston. And again, thank you, Darryl. With that, I don't see any other questions. So, Darryl, we're going to say thank you so much for your time, for joining us today. We appreciate your insights into CMS and healthcare reform, and we'll be continuing to move forward in the coming months. And thank you again so much for your time. And again, to everybody online, we will be posting a recording of today's session at the Healthcare Reform Study Group website. And along with Darryl, if you'll send me your slides, I'll post those as well for people to reference later on.
Okay, and I'll definitely have to get approval for that. But I did put my phone number in there. That is my office number. It does ring over to my CMS cell phone. So if anyone wants to get in contact with me, that is the direct link to me. So.
All right. All right. Well, thank you again. And everyone, have a great morning.